Okay, so let's start with leukemia. So the first question that that's often asked by people who study hematology is, what's the difference between leukemia and lymphoma? Okay, so that's why I started the chapter with leukemia versus lymphoma. So the main difference between leukemia is you get two different things. You get to start with two different things. Leukemia is more of a problem with the fluid portion of the blood. So we're going to draw a drink there. Wait. So for you guys to get to easily remember it. medyo- Ah, so leukemia is like this. It's like a drink. Okay. Um, I don't know. We could say lemon. So this would be your lemonade, all right? And you can change the color. That would be your lemonade, okay? While lymphoma is the actual lemon, the solid portion of that of a particular disease. Now, what's the difference? It affects the liquid portion of the blood. Leukemia affects the liquid portion of the blood, while lymphoma is actually a solid mass. So that's the difference between them, okay? So that's the main difference between leukemia and lymphoma. There's a solid mass in lymphoma, and for leukemia, it's basically going to be a cancer in the blood or a malignancy. We can call it a malignancy, we can call it a neoplasm, anything that has something to do with cancer. All right? Somebody sent in a chat. Sorry, di pa gumagana yung screen. Terribly sorry. Let's try again. All right, sorry. Hindi pala, sayang hindi niyo nakita ang drawing ko. Ang napakaganda kong drawing. Sorry. Ulitin natin. Okay? So, mm, window, PowerPoint presentation slideshow. Can you guys see it now? All right. So it's now on a true or false question, correct? Correct? All right. So again, balik tayo sa kaninang slide natin. Ang pangit ng drawing, pero hopefully you guys get to understand. Leukemia is the liquid portion, hence my drawing, which is the lemonade, and lemon, which is actually the solid form of your leukemia. Okay, so neoplasm in lymphoid tissues. It's a neoplasm in the lymphoid tissue, and that's for lymphoma, and leukemia is neoplasms in the blood cells or the bone marrow stem cells. Okay? Now, true or false? Lymphoma and leukemia may overlap with each other in a single case or in a single patient. Anybody answer? True or false? I want to see people from the chat. Can it hindi talaga gumagalaw yung screen kasi hindi ko pa ginagalaw. Nasa true or false pa lang tayo. Don't worry, Earl. It's okay, Earl. The screen is not moving because there is literally no screen moving. There's literally nothing moving in the screen. So the answer is true. All right. Sorry, I pressed the down button, and so we're going to start it again. We're gonna start anyway. Um, so yes, it's true. Leukemia and lymphoma can occur in the same case. I know you would be very unlucky to have both of them, but it can occur. Okay, so in cases like CLL and SLL, and Burkitt's lymphoma and Burkitt's lymphoma. Okay, there are more of these, but the commonly asked questions in the board exam is usually CLL, SLL, Burkitt's lymphoma, and Burkitt's leukemia. All right, so please don't forget this too. Okay, and this one. Okay, what's CLL? Can anybody transcribe CLL for me? Hmm, what about Earl? Yung nagsabing hindi gumagalaw ang screen. What do you mean by CLL? Earl, are you there? Okay, I can understand you're Googling. Don't worry, I can wait. All right, very good. Chronic lymphocytic leukemia. What about SLL? Can anybody tell me what is SLL? It's the same thing, lymphocytic lymphoma, but what is L? L is small cell. Yes, very good. Thank you. Thank you so much. All right. So what about Burkitt's lymphoma? What is important about Burkitt's lymphoma? What do we need to remember? This is a high yield question. I'm going to put a star on this one again because I know it's important, especially in the board exam. What do we need to remember about Burkitt's leukemia? It is FAB classification 3 or type 3, FAB type 3, okay? And the appearance of I'll use a different color. The appearance of the cell is like this. It's blue, of course, because there's intense basophilia, and there is appearance of bubbles or vacuoles. It's the only type of ALL classification under FAB that has large cells and the appearance of vacuoles. So please don't forget about these ones because these are the two types of questions that you might encounter in the board exam. All right? The fastest and the easiest way to detect leukemia is, of course, using your blood smears and peripheral blood smears and bone marrow aspirates. Okay? Cancer starts with the B cell. Terribly sorry, but I didn't understand what you said. But chronic lymphocytic leukemia is the correct answer for that one. Sorry, friendies, I didn't understand what you said. All right. Yeah. So that's the basic way or the easiest way for us as medical technologists to detect to detect leukemias. Now, true or false? True or false? Medical technologists are the first people to see cases with with leukemia. True or false? You can type it on the chat. Medical technologists or clinical laboratory scientists are the first people to see cases of leukemia. True or false? You can type it on the chat. You can say it on the mic. It doesn't matter. Hello. Nobody's typing. I'm expecting people to type, but yeah, it's true. Of course, people are amazed that our some healthcare professionals rather are amazed at our job because we're the first people to see malignancies such as these in the clinical laboratory. Actually, before the doctor sees the patient's result, we're the, diagnoses a patient's result. We're the first people to see the malignancies that can occur in the patient. And actually, this is what we call a critical value. For instance, if a bone marrow preparation is created by a medical technologist, he or she needs to look at the smear, correct? If his smear is correctly stained, the cellularity is well distributed, and when a technician or a laboratory technologist perform these particular tests, we often look at the slides first. And oftentimes, especially when I was working in the Philippines, um, when we make smears for platelet counts, we're often shocked by cases that show malignancies like these. And it's a critical result. When I say a critical result, it's a result that can cause harm to a patient if it isn't reported immediately. Another term for a critical result is a panic result. So a panic result and a critical result are results that need to be reported immediately. Otherwise, a patient's life might be in danger. So any form of blast cell or um, actively dividing cell in the in either of these two tests or samples that you receive or prepare would be a critical result. So please be mindful of those things because they might ask you in the board exam which of the following is a critical result in the laboratory. Okay? All right. Now, let's move on to summarize the common hematologic malignancies. So we have several types of hematologic malignancies. We can divide them into leukemia, lymphoma, and myeloma, which will be the topic of our discussion for today. So for leukemia, you have four. We're going to move on with the slide. ALL, AML, CML, and CLL. Look at how I arranged the leukemias. This is how we're going to discuss it later, and there's also a reason why I put it like this, so that you will be able to remember the age distribution. This occurs in children around 1 to 10 years, newborns to 1 to 10 years old. This will be for 40 to 60. Okay, this one is for 60 and above. That's how I modify the discussion. Some books, they jumble it together and it often confuses students. So what I did for you guys, since I love you guys so much, I prepared it in such a way that you guys will be able to remember it easily. And I even modified the entire lecture based on this one because again, this is important. Why is this important? You can actually diagnose you can actually make a guess on what type of malignancy or leukemia your patient is having, especially if they ask you a question like this. 60-year-old patient. I'm gonna read out. Wait, I think I typed it here somewhere. Uh, yeah, this one. 71-year-old female came to the OPD department for a routine checkup. Her CBC was normal, and there were no unusual signs and symptoms found on her physical examination. Urine was collected, normal. There's no hemoglobin and bilirubin present. Upon making a smear, technologists noted that she saw smudge cells. Which of the following will be her would be the probable diagnosis? That's a question actually in the board exam September 2020. September 2020. One of my students actually sent that question to me because she was thankful enough that I created this particular shortcut for her. Now, 70-year-old, the patient was 70-year-old, a 70-year-old female. What do you think would be her diagnosis based on what I just told you now? Anybody can answer? Very good. See? That's why it's very important for you guys to remember it in this particular arrangement. Okay? Hannah and John Mediana, you are correct. You are correct. All right? Clap, clap for both of them. Okay? Now, for lymphomas, we have Hodgkin lymphoma and non-Hodgkin's lymphoma. What's the difference between these two? Well, if it's invasive and it has, wait, let me change the color of my highlighters. We have two types. We have a cell. Remember what is my drawing earlier? What cell are we looking for when we're when we want to see when we that is pathognomonic pala or pathognomonic for Hodgkin's lymphoma. What's that cell? It's can anybody answer? You have Ina Joseph. You know the answer. What's the pathognomonic cell or abnormal cell that's usually found in the bone marrow aspirates of patients with Hodgkin's lymphoma? Hannah, it's not is we want to be much more specific. What particular lymphocyte? It's actually an abnormal cell. It's your WBC, no. Reed Sternberg, yes, correct. Reed Sternberg. Who was that? I didn't see the name. Sorry. So with Reed Sternberg cells, automatically you would know that this is a Hodgkin type of lymphoma. What about a non-Hodgkin lymphoma? Don't worry yourself about it. Why? Anything without the Reed Sternberg cell that is a lymphoma or that is a mass is a non-Hodgkin lymphoma. That's the reason why we don't usually talk about it. This is usually reserved for medical students who are taking the physician's licensure examination. And it's not our topic. Okay? What we need to know as medical technologists is the Reed Sternberg cell. Okay? Why? Because the Reed Sternberg cell looks like an owl. That's why I'm drawing it here right now. I don't know if it looks like an owl for you guys, but that's the appearance of it. Eccentric two cells with eccentric nucleus looking down at each other. All right? Cross-eyed, so to speak. All right? What about for myeloma? This myeloma is actually a plasma cell dyscrasia. So when I say plasma cell dyscrasia, there's a problem with the plasma cells. It's producing abnormal proteins, specifically antibodies. Okay, they could be either IgG or IgM, depending on what type of disease we have. So we only have two types that we're going to discuss that is considered to be high yield in the board exam, and that's your multiple myeloma. And I forgot to write here Waldenstrom's macroglobulinemia, but we will discuss them together later on. Okay, so what's the spelling? Waldenstrom's. So that's the one with two dots, the O with two dots on the top. Okay, Waldenstrom's, the one with this one, an O like this. So Waldenstrom's. Okay, so that's the basic hematologic disorders that we're going to talk about today, and hopefully this will be this will marinate in your noggin for a very long time, guys, because this is important. A lot of the questions in the board exam can come from this particular slideshow alone. All right, summarize the main differences between normal cell proliferation and neoplastic cell proliferation. Ah, this is an important question. What is proliferation? This is basically cell division. Okay, so normal cells proliferate on normal circumstances. For example, infection. For example, inflammatory reaction to either trauma or microbial invasion. Neoplastic cells, they proliferate randomly. Okay? Now, I'm going to cite several differences between the two of them, and it is again in a form of a wonderful graph. Normal proliferation is polyclonal. What do I mean by polyclonal? It's not just one cell that's the problem. Why? Whenever you have a particular infection, remember this. In acute infections, the which WBC will increase? Can anybody say? Can anybody type or say it in the microphone? Whatever, however you want to answer that question. Anybody? Acute infections. What is the major blood cell that increases in number or proliferates? Acute infection. So that you guys get to understand what's the difference between polyclonal and monoclonal. Anybody? Chat box, or you have you have five, I think five to choose from. You have neutrophil, monocytes, eosinophil, basophil, and lymphocytes. Which of these five will arise in acute infections? Neutrophils, correct. But but again, I don't like people who answer with question marks, huh? I don't like the answers with question marks. Not the people, sorry. I don't like the answers with question marks. It means that you're uncertain. So I want it without question mark next time, huh? No, I don't like. No, no, don't worry. I don't hate the person. I hate the answers with question marks because it means that you're uncertain, and we don't want to be uncertain in. So please, please. Sorry if I said something a little bit inappropriate. It's not the person that I hate. It's answers with question marks. All right. Okay. So in acute infections, neutrophils will proliferate. It will undergo chemotaxis and it goes to site of infection. Yada yada yada. The next one to go there is your monocytes, and they will proliferate as well because they function as your antigen presenting cells. But don't worry, neutrophils are macrophages as well, and they are considered as APCs as well. But the best one would be your macrophages. Okay, macrophages will come in. Macrophages will then release cytokines to activate to cause the proliferation of the other white blood cells, and that is what you call polyclonal. Okay, each of them will increase at their own rate. They will increase in different levels in their own rate. While in neoplasms, there's a problem with one cell line. For example, I'll give you a common example. In cases of ALL, ALLL3, Burkitt's lymphoma. Um, no, I don't want that one because that's a little too confusing for you guys. It's a little too advanced for you guys. Um, let's start with AML2. AML2, M2, or the FAB classification M2 is acute myelomonocytic. Myelo, 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 promyelocytic. M3, sorry, I'm talking about M3. So M3 is promyelocytic. So the problem is the promyelocytes. Okay? Why is it a problem? Because why is it monoclonal? Because it affects only one cell line in the WBC series. Okay, as opposed to this one, normally they increase as a whole. But in neoplasms, there's only one cell that's affected. It's going crazy. It's doing a lot of it's doing a lot of bad things to the body, and that is considered to be also irregular. So that's irregular. So there's no reason for them to multiply. Okay? As opposed to proliferation, it's regular. Okay? There is a reason. You understand? It's not regular Coke or irregular Coke, guys, huh? It's like regular because it's normal, and this is a normal body function. And neoplasms, they just divide just because they feel like it. All right? There's no actual reason why. There's no signaling molecule that causes the cell to proliferate. Okay? And another one, the last one that we're going to talk about, is it reversible? Yes, of course. Acute infection resolves. The normal white blood cell count will return to normal. Okay? So, resolution. So, it resolves. What about for leukemia or neoplastic cells? They don't reverse. They continue to proliferate and damage the body, as that's the reason why it's important for them to be diagnosed so that people can be treated. And neoplastic stem cells are a bad thing because again they are capable of replacing the stem cells in the bone marrow. They are capable of invading the excuse me. They're capable of invading the bloodstream, and therefore they are also capable of metastasizing to different organs. That's the reason why they are they are bad cells. Okay? Neoplastic stem cells. So again, what is neoplastic stem cells? Basically, these are malignant stem cells or cancerous Other terms for that one, you guys would know it already. What's neoplasia? Neoplasia, you've already taken your histopathology classes, and it's oftentimes discussed in this particular manner. All right. Now, why is it important to discuss the incidence rates? Because leukemia can be diagnosed based on these two populations, adults and children. How so? Well, children's adults, sorry, are much more likely to develop leukemias in their lifetime than children. All right, so that's the reason why I put it here. Is it gonna be asked in the board exam? Yes, it's very common. It's a common question, and I would consider it as a high yield question. So I'm gonna put it here. Okay, put a star on here so you guys can remember. All right. Incidence rate of leukemia between males and females. I think everybody can answer this one for me. Which gender, or rather, which of the following sexes are most likely to be affected by leukemia? Males or females? John Mediana said male. Ronaldin said male. April said male. All right. Earl said female. Okay, he's the only one here. All right. Does anybody want to join Earl? He's a feminist. All right. Who else? All right, people, you can answer. Don't worry. It's a poll. All right, female. Okay. Okay. Oh, Vanessa corrected herself. Oh, self-correcting si Vanessa. All right. Female. All right. Female. Female. Male. 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 Female. Self-correcting si Vanessa. All right. I love it. All right. All right. So that's everybody. I don't think that's everybody. I want to see how everybody would answer. This is the reason why I didn't want to send you guys um, the PowerPoint presentation. It's because I want you guys to answer this question as honestly as you can. All right, who else wants to participate? So most of the students they answered male. All right, Apple said female. All right, let's go, guys. Let's go. We have 30 seconds to go before I read the answer to you guys. Okay, female, male again. Male. Jeremiah said male. Zyrene said male. All right. Buslon Anime said male. All right. Precious said male. Okay. Anybody else? 10 seconds. 5 seconds. Five, four. John Ilagan said male. All right. Angelica said male. All right. Polls are closed. So majority of the students they answered male. Now, the answer is actually female. Male, sorry. Sorry. Males. Sorry, ako pala ang namali. The answer is males. All right. Now, what's the reason? How do we remember this? Solid tumors is actually very common in female. All right. Solid tumors or solid forms of neoplasia is common in females. Remember, we have a lot of disorders that we have a lot of cancers in our histopathology classes, and most of them they cover a lot of most of them the demographic is towards females. Okay, and for leukemia, it's actually common in males. Okay, so think about a lot of the celebrities that died from leukemia. We have Chadwick Boseman, he died from leukemia. Who else? Who else? What's that? Who's that person that recently died? He's a Filipino rapper. Francis M. He died from leukemia as well. All right. So you just remember those two things. Is it a high yield question? Of course. Demographics is one of the favorite, or demographics and epidemiology is actually one of the board examiners' favorite questions. Okay. So it's more common in children, more common in females. Males. Again, males. Okay. So sorry, Earl. you're being a feminist. However, being a feminist in this particular context is not going to work out in your favor. All right? Okay, let's move on. Um, what is the most common classification of leukemia that is encountered in the clinical laboratory? Okay, so we have choices, guys. This is your choices for that particular question. ALL, AML, CML, CLL. All right. I want you guys to answer same answer like the same time. Those are your choices: AML, ALL, CML, and CLL. What is the most common classification of leukemia encountered in the clinical laboratory? Polling starts now, and we're going to do a timer this time. I didn't. CLL, okay, okay. Timer starts now. People can answer if you want, if it's okay. Participation class. This is a participation. Okay, all right. People said CLL. Most of the people answered CLL. CLL, CLL, CLL. All right, all right, all right, all right. CLL. Somebody answered differently. Who answered differently? AML. Ina Yusuf. All right. CLL. I think everybody's copying everybody. Come on, people. Have a different. Have a. I'm not giving choices, but I'm not asking for your reason. So it's very rare for me to do this, but I think it's one way for you guys to have participation. All right, CLL. Who else? We still have 17 seconds. CLL also. All right. Um, there is Christine combined her answer. Christine combined her answer. Christine, ha? That's very mischievous of you, ha? There's no CLLA, ha? You're trying to confuse me, ha? Okay. ALL. Okay. Almira said ALL. Um, Maria Bulawin is trying to be cheeky. She said ALL and CML, CLL and AML. All right. Can only choose one. All right. So okay. Polling ends now. Let's see the answer. So most of the students answered CLL, and there's only a handful of you who answered ALL, which is actually the correct answer. I think there's only two people. Christine answered in a combination form, but I'm not gonna accept that one. So the correct one is ALL. All right. So I think there's one person who answered ALL. Yeah. So congratulations, Almera. You answered correctly. Okay. All right. What's going on? Mhm. All right. Wait. What's going on? What happened to my lecture? Why is it? Why isn't it showing? Most common that's encountered. Ah, okay. Blah blah blah. Okay, I left it blank. I'm supposed to add some details, but then I removed it. Okay, so summarize the distribution of leukemia based on age group. Okay, can you guys see the PowerPoint presentation? All right, so summarize the distribution per age group. So again, I mentioned it already. Newborns to 14 years old, ALL, CML, and AML are closely tied together. It's at 40 to 60 years old, and CLL is greater than 60 years old. All right. So why did I put it in this chart? I want you guys to remember it. So I'll put a star on it so you guys can remember why it's important. Okay. Summarize the difference between acute leukemias and chronic leukemias. Now, the difference between them is that the cells are much more younger. Everything about the thing that you guys need to remember for acute leukemias is that everything is younger. Okay, whether it's the cell or whether it's the person being affected. And for chronic leukemias, these are for much more mature mature patients. Okay, it's for much more mature patients and mature cells. Okay, so for acute leukemias, there's more than 10% blasts seen in the bone marrow, while for chronic leukemias, there is less than 10% blasts seen in the bone marrow. Okay, and it's also seen in younger patients. Acute leukemia is also seen in younger patients, and chronic leukemia is often seen in patients who are much more older. Okay, but sir, you're going to ask me, Francis M died at the age of 37. He's supposed to have, he's supposed to be at around 40 to 60 years old, right? I know someone is going to ask this question. I can feel it. Francis M died at around 37 years old from acute myelogenous leukemia. You said it's for younger patients. Well, um, I'm going to answer this in a very simple manner. The reason why some patients die at the age of within that gap, there's a gap between 14 to 60 years, 14 to 40 years old, was because they already have the disorder at birth. It wasn't detected. It wasn't. It wasn't detected even in peripheral blood smear. Usually, these are patients. These diseases are insidious. They can't be seen or detected without actually looking for them. So routine blood smear, nobody does routine blood smears, right? Your doctors won't come to you and say, "I think you have leukemia." That's a very strange way of diagnosing a patient. You usually have to follow a particular symptomology. Okay, so there's an algorithm that they have to follow. Patient has anemia, we test for anemia. Patient looks like he's suffering. Patient doesn't look like the patient's clinical presentation and laboratory findings doesn't correlate with anemia. Maybe we'll try peripheral blood smear, and that's the time that they usually get detected. Okay, so Francis M might not have the signs and symptoms of acute lymphocytic leukemia, but the reason the reason why he died at that age is is not because it's unusual. He's an unusually rare case, but rather the cancer cells have developed over the years. Okay, cancers can kill you as early as right now. Okay, it has to develop. Have to the cells have to divide at a very long rate, um, at a very long period of time before they can actually present signs and symptoms that might be noticeable by your physicians. So, although he has acute lymphocytic leukemia, it was undetected. It remained undetected, and or should I say, it's not dormant, but it remained undetected at his early stages of life, and then suddenly it was detected because he had some sort of signs and symptoms, yada yada yada, and the doctors had follow up on that one a little bit too late. All right, so these are solid tumors of lymphoid organs. So we're moving on to our next topic, which is basically lymphomas. We've answered this one already. What are the two types of lymphomas? Okay, I wanna hear from the students. What are the two types of lymphomas? I wanna hear from a specific person. What about Maria Bulawin? She tried to answer two. She wanted to be safe and answered two from my previous question. Two of the four questions. Maria Bulawin, are you here? All right. So, based on our discussion, what are the two types of lymphomas that I've already mentioned in our summary? All right, wonderful. Now, since you've already have your mic open, all right, don't mute your mic yet. I still have a lot of questions for you. Okay. How do you differentiate, or what cell is will differentiate Hodgkin's lymphoma from non-Hodgkin's lymphoma? You can describe it for me. Don't worry. I drew it for you guys like several times now. Hopefully you remember it if you're paying attention earlier. I'm gonna draw it. Uh-huh, it's okay. Don't worry. This isn't an exam. Yes, very good. And what does Reed Sternberg cells look like? I'm drawing it for you because in the Philippine board exam, they will not show you the appearance. They will describe it for you. So I want you guys to remember it. Look what it does it look like? Look at the drawing that I'm making for you. What does it look like? Yeah, so it has an owl's eye appearance. All right, owl's eye appearance, and it's making you hoot hoot. Okay, thank you so much, Maria Bulawin. Okay, all right, so that's a Reed Sternberg cell. That's how you differentiate um, Hodgkin's lymphoma from non-Hodgkin's lymphoma. Okay, Hodgkin's lymphoma and non-Hodgkin's lymphoma. What cells is found in cases of Hodgkin's lymphoma? We've already answered that one. That's Reed Sternberg cells. All right. What are the types of non-Hodgkin's lymphoma? We have two types actually. We have the indolent type and the aggressive type. Or I'm sorry, T cell lymphoma and B cell lymphoma. Sorry, it was a little bit advanced. For B cells, we have the indolent type. B cell lymphoma, we have the indolent type. Indolent type. And for B cell, another one is the aggressive type. All right. So see, indolent type, he's a little bit more chill. Okay, and it's slow acting. For B cell lymphoma, it's a little bit much more. It's a little bit stressed out. It's literally going to stress you out because it's invasive and it's much more fast progressing. The progression of the disease is extremely fast. Okay, so what are the subtypes of non-Hodgkin's B cell lymphoma or B cell um, call this B cell non-Hodgkin's lymphoma? So I mentioned that one already, the aggressive type and the indolent type. Examples of B cell non-Hodgkin lymphoma. Um, I don't think it's gonna be asked in the board exam, but anyway, I'm going to help you guys out. Burkitt's lymphoma and mantle cell leukemia. All right. So we have Burkitt's lymphoma and mantle cell lymphoma. What are the examples of indolent type Hodgkin's lymphoma? You're going to be it's easy for you guys to remember this. For indolent type, it's much more chill because it's located in one part of the lymphoid organs. Your lymphoid organs have what you call the follicular area and the marginal areas. Okay, the marginal areas is in between the follicular area. So you're for based on that one, you can remember that there is follicular lymphoma and marginal maltoma. Okay, you already answered two. But what about hairy cell leukemia? I thought you said that that lymphoma is different from leukemia. Actually, this is true. However, for hairy cell leukemia, it arises from this particular lymphomas. Okay, so it comes from. Sorry, my drawing has everybody a little bit confused now. Okay, now I'm gonna erase the drawings. So it actually arises from one of these two. Okay, now what are hairy cells? Hairy cells are your lymphocytes that have escaped the lymphoid tissue. These are malignant lymphoid tissues or lymphoid cells that have hair-like projections. So imagine Son Goku with hair-like projections. And they're usually stained with what we call tartrate-resistant alkaline phosphatase, and it can be demonstrated in hairy cell leukemia only. All right. So please don't forget TRAP. This is another high yield question, and you might be asked this question for well, but it's easy for you guys to remember it because usually I think I encountered this one in a practice exam. I'm not sure whether it was for ACP or for the local board exam in the Philippines, but what I do remember about it is that it's always presented as a hair-like projections in lymphocytes, spindles, spindle-like projections on the lymphocytes, and almost always it would it would have a certain question about the stain that you're going to use, and that's actually tartrate-resistant alkaline phosphatase test stain. All right, so please don't forget the trap. You trap your hair with a trap stain. You trap your hair. So I'll put a mouse trap here. That's your um, that's your Son Goku character, and it gets trapped in the mouse trap. So trapped by alkaline phosphatase. Okay, hair cell leukemia cells are trapped by tartrate resistant alkaline phosphatase. All right, so you guys don't forget. Okay, so I make a lot of drawings for this one because there's a lot of things to remember for hematology, and I think these types of things will make a lot of neural connections for you guys. All right, now I'm going to introduce to you guys about acute leukemias. But before we do that, I'm going to ask you guys a couple of questions first. There is a 60-year-old female, a 60-year-old male with signs of anemia. What would be the possible these are just practice questions. 60-year-old male with signs of anemia. So signs of anemia, pallor, weakness, malaise, pain in the bones, blah blah blah, yada yada. What would be the possible diagnosis? AML, ALL, CLL, AML, CML, or CLL. What would be the possible diagnosis? More than one answer applies. Anybody answer? Anybody? All right. I'm gonna start timer for. All right, timer. ML. How many people have answered already? AML and CML, CLL. All right. Okay. Timer ends now. All right. All right. Timer ends now. More than one answer applies. Jovel was actually the one. Jovel and Earl are actually the two people who answered more than one. However, their answers are a little bit incomplete because the correct answer is supposed to be AML, CML, and ALL. That's the correct answer. Why? Because as I mentioned before, guys, it's uh, the disease. The distribution of the disease is between the distribution of the disease is 40 to 60 years old. So CFA, sorry, not ALL. Correct one is AML, CML, and CLL. Sorry. That's the correct one, and the one that the latest one that I actually post, the latest one that I sent onto the chat. All right. Why is it these three? Why not ALL? Because as I mentioned before, it's newborns to 14 years old, while 40 to 60 still falls under the CLL. Okay. No signs of leukemia. Asymptomatic. With lymphocyte, what about if I ask you guys the same question? All right, I'm gonna ask you guys the same question, and then on I'm gonna add I'm gonna add a little bit more detail. Hmm, What should be the what should be the what stage? Yeah, that one. What stage will the patient no, no, no. Later, I haven't discussed about. All right, let's continue anyway. um, I'm gonna introduce you guys to acute leukemias. All right, and it's important for you guys to remember certain diagnostic and prognostic markers for certain diagnostic and prognostic markers for acute leukemias. Why is it important? Is it going to be asked on the board exam? Of course. Why would I put it here if it's not going to be asked on the board exam and in your other certification examinations, right? Anyway, how is acute leukemia differentiated from other types of leukemia? From the other types of leukemia, it has more than 20% blasts in the bone marrow. Take note of 20% blasts. All right? 20% blasts in the bone marrow. What are some of the ways to diagnose and classify acute leukemias? Well, you can diagnose it with several ways. In several ways, you can use blood cell morphology. All right, using your what? Using peripheral blood smear or bone marrow aspirates. You can also use karyotyping, or you can also use what else can you use? CD markers or immunophenotyping, and lastly, we can use molecular studies or cytochemical stains rather. So please remember the cytochemical stains that you might encounter. For this particular topic, you need to remember about TDT, okay, PAS, MPO, and what else is there? Non-specific esterase, okay. There's I think five cytochemical stains that you need to remember. Ah yes, the last one is SBB. What's that? What does SBB mean? Okay, SBB. Anybody from our audience? What does SBB mean? I want to ask somebody again. Mm, let's see who. Sudan Black Beer. Yes, very good. Gina answered first. Very confident without any hesitation. However, very particular ako sa ang hirap i-please. Ang hirap ko i-please, no? Guan Yin was the only one who was able to answer for me correctly. Why? The the um the capitalization. But anyway, no, I'm kidding. I'm kidding. I will answer correctly. Everybody answered correctly. It's actually Sudan Black Bee. Now, want you guys to remember Sudan Black Bee detects the fats or the lipids in the cells. The lipids. Okay? Lipids. Myeloperoxidase detects the granules. Periodic acid shift detects carbohydrates or glycogen. TDT detects the DNA. All right, or stains the DNA. That's the only thing that you guys need to remember. All right, so cytochemical staining. This is gonna be important later on when we discuss them all one by one. All right, so then black B is correct, guys. SBB. What about PAS? What do you mean by PAS? Periodic acid shift. What about MPO? Taray. So, sasagutin lang ngayon lahat. Oh gosh, I love it. All right, very active ang mga students today. I think it's because you guys have already eaten lunch. All right. In general, what would be the range of the following acute leukemias expected? What would be the range of the following expected for? Okay, so range. I think that question is a little bit confusing. Let's try to edit that one. I think the question is a little confusing for you guys. Hang on, hang on a sec. What would be the range for CBC? I'll try to correct it. Okay. What would be the CBC ranges of the following? What would be the for acute leukemia? So I added the following. So it's supposed to be RBC. What's that one? Um, platelets, WBC count. What else is there? Ah, blood smear. So blood smear. So these are the things that you need to remember. It's normocytic, macrocytic. It might be at MCV greater than 80 usually. The platelets are less than sorry. Oops. The platelets are less than 100,000, and WBC count can range to 10,000 to 100,000. And it could be a little bit more, it could be a little bit higher, but should be within this range to be classified as an acute leukemia. All right? Now, describe the bone marrow cellularity of patients with acute leukemia. So these are patients who have abnormal cellularity, and therefore they are hypercellular. These patients have a hypercellular bone marrow. What do I mean by hypercellular? The myeloid erythroid ratio is actually abnormal. In what way? The myeloid erythroid ratio, ME ratio. What is the normal ME ratio of patients? ME ratio means what? ME ratio is the number of myeloid precursors versus the erythroid precursors. Normally, it's 1 is to 2 to 1 is to 4. But for patients with acute leukemias, it's actually 1 is to 2, 1 is to 20. It's so abnormal that the erythroid ratio is being overlapped. Okay? Okay? So that's the myeloid erythroid ratio. Now, let's begin with 20% blast. Forgot to mention again, we're going to repeat it again. 20% of blasts is present in the bone marrow. Hypercellular, and 20% of blasts is present. All right, next. Summarize the difference between AML and ALL in terms of lineage. Lineage, of course, AML is myeloid, okay? um, from the name itself, and this one is from the lymphoid lineage. Lymphoid, so lymphocytes. Presence of our rods. Our rods are actually precipitates of granules. Therefore, which of the two has more granules? The AML ones. So it's positive for here, negative for here. Periodic acid peroxidase reaction. Again, peroxidase comes from our rods. So therefore, it will be positive here and it's negative here. Let's double check our work. See? Positive, positive, negative, negative. Correct? Easy peasy, right? What are our rods? These are our rods. I'll draw it for you guys. Suppose you have an abnormal cell. This is its nucleus, nucleoli, and the nucleus is here. All right, I'm gonna draw it for you. Just want you to. I drew it like this because I want you to see the outline of the nucleoli. All right. Then our rods would be here. They're actually diffused all over some of the cells. Basically, basically these our rods are significant, especially for M0 to